So, the definition of acute kidney injury is the rapid loss of kidney function during hours or days with dysregulation of volume and electrolytes leading to metabolic waste product accumulation. And acute kidney injury has several definitions. Here in this, we specifically address the Valve Academy Research Consortium 2, the VARC2. And as you can see here, we can see that it has different grades with serum creatinine increasing and actually a decrease in urine output. And acute kidney injury is a frequent post-AVI complication. When we're looking at the literature, we have various degrees that it's reported, and it really is related to the definition of AKI, which was chosen by the people who looked at it. AKI affects TAVI outcome and survival, and the presence of atherosclerotic disease in renal arteries might be related to post-TAVI AKI. And no studies have evaluated the renal arteries for the presence of renal artery stenosis in pre-TAVI evaluation. So our objective was to investigate whether the presence and extent of atherosclerotic disease in the renal arteries is related to post-TAVI AKI. And as I mentioned earlier, AKI was defined according to VARC2 with a score greater than 1. And we addressed a post-TAVI AKI group and a post-TAVI non-AKI group, which actually included patients who were matched with creatinine greater than 1.4. So patients with initial renal dysfunction. And these patients were compared for the presence and severity of renal artery stenosis. Renal artery stenosis evaluation was performed using the pre-TAVI and the CT scans, using curved multiplanary formats along the renal arteries, using the IntelliSpace portal. And renal artery stenosis was graded as follows: none, less than 50%, greater than 50%, and greater than 75%. And the kidney size was also measured using MPRs. In the acute kidney injury group, we had 69 patients with the VARC2 criteria and a mean age of 82. And the non-AKI group included 36 matched patients, as I mentioned earlier, with a serum creatinine greater than 1.4 and a mean age of 82. And respectively, here we had 60% females, here we had 49% females. For each patient, the ostial and the proximal third of both renal arteries were evaluated, and that's 4 renal segments were evaluated per patient. So if we're looking at renal segments, in the AKI group, we had 270, we had 276 segments, and again, looking at the ostial and proximal third segments, and in the non-AKI group, we had 144 renal segments. When we actually look at the presence of renal artery stenosis less than 50%, we can see that the difference between the two groups is non-significant. However, when we're looking at the presence of renal artery stenosis greater than 50% and greater than 75%, this was significant when we compared the renal segments in both these groups. Looking at the kidney size, there was no difference and it was no significant. Let's take a look at just an example. Here we can see a very tight ostial stenosis in the left renal artery, and again a significant stenosis, less tight, of about 70%, and on the right-sided kidney, and we can see how we measured the kidneys as well. So the study had several limitations. Again, it was retrospective and signal center, and there was no standard of reference other than the CT scans. So to conclude, there was a statistically significant higher rate of renal artery stenosis greater than 50% in the AKI patients as compared with the non-AKI patients. This suggests that the presence and severity of renal artery stenosis might be a risk factor for post-TAVI AKI. Thus, we propose that renal artery evaluation should be considered as an integral part of pre-TAVI workup. And of course, further studies are needed in order to elucidate the precise mechanism of renal artery stenosis in AKI patients. Thank you very much.